Welcome to the Red Clinic Podcast. I'm Dr. Schwalen, licensed psychologist and expert in the treatment of eating disorders. Today, we're going to do what we do best. I have a very special guest on the show with me today, Dr. Setliff, who is a just amazing colleague of mine. I'm just so touched that you came in today. I would love it if you would just introduce yourself and give us a little bit of background, and then we'll have a really good conversation.
Okay, that sounds good. I'm Dr. Setliff, Stephanie Setliff. I'm a child and adolescent psychiatrist. I treat eating disorders. Right now, my job title is Regional Medical Director for Eating Recovery Centers, treatment centers here in Texas. There are 7 sites. But that's not what I started out doing. I started out thinking I would be a psychiatrist that treated kids, and I would treat all kinds of disorders, but it turned out that eating disorders were the ones that I was drawn to. Those families were the ones that I stayed late for when I was in training, and they're the ones that to this minute, if money wasn't a currency and I had to work for free, that's what I'd be doing. So I feel lucky.
That's amazing. So you love what you do.
I do love what I do.
Okay, well.
So much. I just can't believe I get to do it. I say it almost every day. I can't believe I get paid to do this work.
That's amazing. What a great feeling. So you came on today because we just wanted to talk. We want the audience out there to really, I had some thoughts before we even started the show today about, what is the audience out there kind of thinking about? I know that with the pandemic, things have really changed.
Yeah.
Right?
Yeah.
With the way the clients we're seeing and the way we're even doing care.
Mm-hmm.
Would love to hear your perspective on that.
Yeah. Well, the first week that when everybody really realized in Texas and around the country how bad it was going to be, the call volume for Eating Recovery Center went down. Everybody was scared,
Mm-hmm.
They didn't even know if they could leave their house. And we weren't sure what was going to happen to our patient population. And then they didn't do well. Isolating and quarantining does not work for eating disorder patients. And the next thing we knew, our call volume went up exponentially, and it has stayed up.
Mm-hmm.
And not just for us. Any eating disorder treatment center in the country is on a wait list right now.
Mm-hmm.
And so are we. But what we found is that people got over being scared, because what we would say, they would say, well, I don't know if it's safe to come in. And we would say, well, it's probably not as safe as staying home, but it's probably safer than your grocery store. So people started coming in, but the problem is everybody waited until they were pretty sick and they were really scared. So it kind of compounded the issue, because the stays are longer, they come in sicker, it takes longer for them to recover, longer for them to step down to a lower level of care. We had to cut all visiting off at the end of March last year, which was really hard, because I'm a child psychiatrist and I'm a systems person. I don't believe children can get better without their families. And so we did work out with doctor's orders in a very specific sort of circumstances that parents could visit the littles every 2 weeks. We put all kinds of parameters around it. And then Eating Recovery Center stood up a virtual IOP. 400 people immediately went to virtual. And then 3 weeks later, we stood up virtual partial. But, honestly, we are still behind the 8 ball, and we can't serve all the people that need us.
Mm-hmm.
So that's a little bit of a worry for me. And I feel really proud of the virtual programming and how we got that stood up, because so many college kids were isolated in their dorm rooms, and we were able to give them services that they never could have gotten.
Absolutely. And I will tell you from the outpatient perspective, right at the recovered clinic, because that's what we do is outpatient, you're a higher level of care. And we'll talk about the difference in a second for some people that don't know the difference. We really find it such a blessing, such a gift that ERC was able to, start the VIOP program. We've been able to partner with the VIOP program. Just knowing that that's available to the clients while they're transitioning to outpatient and stepping down it's just been really great. It's been great collaboration, and it's been a great service to the clients.
Thank you. And just for people who don't know, I don't realize that people don't know, but sometimes people don't know. So the V is virtual, and then intensive outpatient programming means it's 3 hours a day, 3 days a week. And what's cool is we get to partner with Dr. Schwalen and other outpatient providers, because you don't come out of your outpatient programming. We just build a foundation under it to try to keep people from having to go up to a high level of care, because when you have to go any higher, you really have to pull out of your life, and that's a big deal for people. You have to come out of school or come out of work. So we like to partner when possible.
Absolutely. And that coming out of your life piece, I mean, I get questions all the time after I do the initial assessment, and the diagnostic impressions are that the client is not appropriate for outpatient and really does need a higher level of care. Parents will ask all the time, if we go to the hospital, doesn't that mean that my child won't be able to do school or be around friends? Won't this be very upsetting to them? I'm so nervous that this might wreck them even more. And my answer to them is, it might, but in the long run, right, it's going to be what's in their best interest. And that's probably exactly what's going to happen in the beginning. Is it's a shock to the system. It's literally being pulled out of your life and having to go do treatment every day, day in and day out. And work is put on hold. School is put on hold. I mean,
that's right.
We just tell the truth, right?
Yeah, the truth is the truth is the truth. I mean, how I think about it is that prior to the opiate crisis, eating disorders had the highest mortality of any psychiatric illness. So one person an hour dies directly as a result of their eating disorder. The opiate crisis came along, and right now about 135 people are dying every day from opiate overdoses, and so we are second. But eating disorders still, that is like an unacceptable number for us to have one person an hour dying from their eating disorder. So as uncomfortable as it is to talk about the truth, as we were just saying, it is the truth, and people need to understand that what we want for them, we don't want their eating disorder, especially for kids, to languish in their development so that they internalize and integrate a maladaptive way of dealing with their lives. Because what's happening in their lives, it's transitions, it's fears, it's a lot of worries, and sometimes it's even pain because things happen in life. And once people, that developmental 12 to 25, which is roughly when 85 to 90% of eating disorders are diagnosed, that's a lot of stuff going on. And I've always thought to myself, if you can navigate that without having an eating disorder or some kind of drug addiction or something else, it's a miracle, honestly.
Yeah, you're right. You're talking about life changes, identity development, going off to college, figuring out how to navigate middle school and high school, right?
Yes.
It's a big deal.
And so no wonder it's 85 to 90% get diagnosed then, right? So I think the faster that we can get somebody in, the better. I mean, I think it is hard for parents, though, high-functioning parents who want the best for their children and want their children to be successful. It just makes sense that they would want to do something in the lowest level of care possible. The problem is that eating disorders just aren't that animal. And if it doesn't get better when you're doing what you do over 4 to 6 weeks, it's not going to get better in 10 to 12.
Right. And I mean, eating disorders are sneaky, they're tough, they're manipulative, they hang on, right? And it really does take a whole village to kick that thing to the curb.
Yeah, it totally does. I mean, and the hardest other thing for parents, I'm just sitting here thinking about, is that the children that are vulnerable, I mean, they're just such good kids, and they're smart, they're motivated, they want to do good things, they want to make a difference in the world. And the honest truth is most of them have been doing good things their whole lives. They've got good judgment about everything, but their eating disorder is a different issue. And even though they are so good and so talented and are going to make a difference if they don't die from their eating disorder, their judgment cannot be trusted. And I think sometimes because the parents are so used to saying, well, what do you think? And then the child gives a good reason for things. When they say, what do you think? And the child says, no, I don't want to go to eating disorder treatment. I think I'll be okay. Sometimes the parents prolong putting them in because they go with that. I mean, I understand it.
No, absolutely. And then that's when we have to talk to parents and help build them up when it comes to, you've got to trust your parenting instinct, and you have what it takes to really be in charge here. I like to use the example of, and I've done this on other episodes, of when your child was 3 and they wanted to play in the road, you moved them because you knew it was in their best interest to move them,
Oh my
right?
God, I love
They're kicking
that.
and screaming the whole way. You're going to let them play in the street, right?
I love it. I love it. I love it. It's like when the 2-year-old says they can swim. Well, you've been with them every minute of their lives. You know they can't swim.
Right.
But you can't keep arguing with them. You can't keep trying to get them to reason.
Mm-hmm.
You just have to say you can't swim, and we're not going to keep talking about it.
Yeah, let's go do something else,
Mm-hmm.
right?
Mm-hmm.
So let's talk a little bit about like what the hospital setting kind of looks
Mm-hmm.
like, because I've talked to the audience all about outpatient. I've dabbled a little bit into what hospitals look like because I've been in hospital settings before as well. But I mean, ERC specifically, if you want to talk about that. And then I'd love to hear what you want to share about the role of psychiatry in the treatment of eating disorders.
Yeah. Okay. Well, Eating Recovery Center is maybe a little bit different than some residential places, but Eating Recovery Center has 28 sites in 7 states, but only 2 have the ability to do inpatient, which is a higher level of care than residential, and Dallas is 1 and Denver's 1.
Okay.
So people come into our place critically ill. In the last few years, it's been really just different because there have been riders on insurance policies where that no matter how sick you are, and I mean like somebody 50% of what they really are supposed to weigh normally can't go out of the state to an acute, which is the only really place that we have where the people go for that level of sickness. So we've had to take higher acuity.
Mm-hmm.
But what I would say is some residential places are in houses. They're in houses, and they
like
have
mansions in a neighborhood.
Oh my
right?
goodness!
Yeah.
And they're so beautiful, and a lot of these stairs and marble floors, and regardless, it's a house. So we don't have that. We have more of but we don't have like a hospital. We have more of like the rooms are more like camp rooms.
Mm-hmm.
I mean so it's that kind of furniture. But we are Joint Commission accredited. We do have the ability to do inpatient, which is a high level of care, really. And to tell you the truth, we have something called intensive treatment unit, which is higher than inpatient. And if we have time, I'll tell you about it. So we have 24/7 nursing care. We have the ability to put feeding tubes in and place them, and frequently we have to. So we can run IVs. We've got full-time medical doctors that are there on site to be able to help us with all of the medical complications of eating disorders. We have a lot of support staff and monitoring. We just have the ability to do that because we really are a hospital, even though it doesn't look like that exactly. I mean, the dining cafe is beautiful on one end of the building with floor-to-ceiling windows, and the community room is beautiful with floor-to-ceiling windows. But it is a place that is that's safe and different from a house.
Okay. Well, thank you for sharing that. And
You're
then
welcome.
ERC also steps clients down to partial hospitalization, and then, like we said, IOP.
Yeah, right. So, I could tell you. So, inpatient, if I could just start there, inpatient and the intensive treatment unit is when people need a lot of medical care.
Mm-hmm.
They might have a lot of vitamin deficiencies. They might have electrolyte problems. They might have heart problems and GI problems. They may have come from somewhere else, like a medical hospital. So it takes a lot of nursing care, a lot of medical doctor support, and psychiatry as well. They're very fragile. Sometimes they're room-based. They don't even come out into the milieu. And then we step them down to residential, and residential is in the same space, but they're able to attend programming in groups with 17, 18 other people. And that's a different level of care and a different level, right, of psychological stability than having to be in your room because even a few people overwhelm you. So that's really residential. And residential, you really think about residential as they might need to weight restore, but it's also just a lot of behavioral interruption in general. And we start exposures then. When you step down, you're leaving 24/7 care. So it's a big difference. And our partial hospital is robust. And people tell me all the time that apparently our inpatient and residential is robust. I didn't know that, but I guess it is. And so in the partial hospital program, it's 7 days a week, 10 hours a day. A lot of the same things happening, family therapy, individual therapy, group therapy, didactics, but you're doing even more exposures because now you're back in your life. You're headed out into your life. And so that is a little bit anxiety producing since something was going on out there that made you have to come in the first place.
Mm-hmm. So there's access to all those triggering things again.
Yes.
But usually just in the evenings, because then the next morning
They go back.
They go right back.
Right. And we I'm a big fan of sleep. I mean, people make fun of me a little bit, but for me, if you're sleeping, you're not restricting, you're not looking at social media feeling horrible about yourself, comparing yourself to people that aren't even real.
Mm-hmm.
You're not cutting, you're not purging, you're not binging, you're not running through the streets of Dallas.
Mm-hmm.
All of these things are unsafe. So really it's just 7 to 10. And then in a slow but organized, stepwise fashion, we help people move from being there 10 hours a day to being there, to leaving and having dinners off and then breakfast off and then other kinds of passes. And then there's a day pass and a weekend pass. And then we step them back to you.
Mm-hmm.
And then we put them in that virtual IOP setting so that they have that foundation, and then they can come back to you and really start working on all that stuff. I had somebody tell me just last week that she didn't like her outpatient therapist and she didn't like her outpatient dietitian. So she came back this week and told me that she realized that she was too sick. She had just started with them. And so what she really didn't like was what they had said.
Yeah.
Which was, you're too sick to be here. You need to go to a higher level of care. And she said to me, they're really nice. Because she had said to me, like, I don't think I'm going to be able to stay with those people. They're so mean. There's something wrong with them. But really, they were really nice, and they just told her the truth.
Yeah. That's how you know you can trust a provider when they say, I'm not going to keep you on my caseload, right? It's not the right thing to do.
Right. I mean, much to their dismay, I'll say. And that's a whole other conversation about how people wind up staying in outpatient too long.
Mm-hmm.
I think it's complicated, and I get it. And I don't envy you. I've got a really easy job compared to you because I have step up potential. I have lots of people around me to support people when they're crumping and really struggling, but you guys don't.
Yes.
Outpatient to me is a wild frontier. It takes a lot of I feel like you have to be really brave to do outpatient work.
Well, thanks.
You're
I
welcome.
think you're really brave.
Well, thank you. This is a mutual admiration brave society.
I know. Yeah. Let's call it that. It's a new episode name, right? Mutual Admiration Brave Society. You got it, Lee?
It's
Okay.
it's true. I think outpatient people, when they don't have access quickly, you don't, because we've got wait lists and we've got all kinds of other things that you have to do to get in. I think it's amazing. It's a lot of work.
There's a lot of stuff that goes on at that level of care. You're making me think of just real life examples right now. So because of the wait lists everywhere, the Recovered Clinic has really had to change the way that we respond to the need. I literally will tell my intake and scheduling department, this was actually a higher level of care referral, but if they waitlist the client, put them on our schedule, and we will support them until their admission date. And that's ultimately the model of care that we have going on right now in terms of just being this little,
Wildly helpful.
Safety net, right? This
It's
screen
wildly helpful to
that's
us.
catching the clients, right?
It's wildly helpful to us, and even our places in Texas that only have partial hospital, they're used to being able to say, hey, you need to step up, but they've had to do the same thing.
Yeah.
They've had to hold people while we are trying to maneuver and get beds available.
Right. And I mean, our goals are maintenance and safety planning and making sure that if anything happens that's a red flag, just get them over to the ER. I mean, what else can we do at that point? Mm-hmm. Yeah. And I mean, other things that we are up against, maybe I can just pick your brain for this for a second.
Sure.
We have clients that, step up, step down. Sometimes they're that relapse client, right? And families are exhausted. They're burnt out. And, like you said, it's easier to blame the treatment team because the eating disorder's kind of hearing. They're telling me something I don't want to hear, and they're not for me. And then we may get like a pediatrician or a physician, an outpatient provider who does the lab work, who says everything's fine, you just need a therapy for anxiety or depression. And so then that bias is confirmed, that eating disorder treatment's not working for me, I don't really need to be in it. And the parents might pull their child from outpatient, even though literally the kid has been hospitalized. Everybody knows there's an eating disorder present, but some other medical provider said, no, they're fine. Mm-hmm. They're stable. Go ahead and make your choices, choose a different therapist. Mm-hmm, mm-hmm. What do you think about that?
Well, I'll tell you what I think about that. A couple things. One, I think medical providers, most medical providers don't really know much about eating disorder treatment. I think that they are inundated and overwhelmed with obesity.
Yeah.
Really, I mean, that's not, or people in larger weight bodies, as they say. No, I mean, I feel like really they do have a lot of issues with that. And so when somebody is not engaging in behaviors that make them continue to gain weight and cause a lot more medical problems like metabolic syndrome and things like that, it's easy for them to say, oh my gosh, finally somebody in my caseload that eats healthy, maybe eats clean, right? So their radar isn't up necessarily for that.
Right.
And I get it. I think, though, that they can change that thought, and it doesn't take that much. It just takes a little bit of education, because I know for sure pediatricians and adolescent medicine doctors want what's best for their patients. They just sometimes don't recognize it. There's a lot of things that happen when labs are drawn. When labs are drawn on kids and adolescents, and I would say some adults, especially like I see kids under 25. That's who I think of as a kid. So a 19-year-old, I really just think of as a kid. They usually don't own their cell phone. They're not independent and emancipated. They still need their parents in a different way than a 6-year-old. But what's going to happen if it's a restricting anorexia? Their body kind of got there gradually, and so their body is going to compensate, and the labs are going to look pretty normal. The EKG is going to look normal unless it's like it's got bradycardia, but it might have a heart rate under 60. That gets explained by the person with the eating disorder, usually as they're athletic and they run a lot, and so they've always had a low heart rate. And parents that don't understand eating disorders say, our whole family's a runner. I bet mine is low too. But the difference is clear that if they had an x-ray of somebody's heart that was dying of starvation, and that's why they had a low heart rate, their heart wouldn't look like a big, beefy tomatoes, like an athletic heart. It would look more like a teepee, and it's not the same. And because what happens is you lose ventricular mass, so those bottom two chambers, you lose volume in those, and it's not the same. It's not functioning the same. The best way to explain it is if an athlete starts doing like high intensity workouts, their heart rate doesn't go up. Their blood pressure goes up. But to get their heart rate up, they have to just work like a dog, right? I wish I could say I know about that personally, but anyway, they have to, it's hard to get their heart rate up to that place. And then they come down and they do it again. In my patient population, it's kind of the opposite. Their blood pressure doesn't really go up. It stays really pretty low. But if they raise their arm to brush their teeth, their heart rate flies up. So it is different, but I think pediatricians and internal medicine, family medicine, I think the frontline people, I mean, they wouldn't know. It's not the most common thing they see. Right? It's just that you have to recognize it when it's there. And the thing about when people don't agree with us, well, job security for us in a weird way is that people don't agree. They don't do what we suggest. So we've got good jobs and we're going to keep them. What I say to people is, this is all I do. I bet you're really good at what you do. This is all I do. So I'm making a suggestion and a recommendation because I think it's the best thing for your family and for this patient, your daughter, your son. But it's up to you to decide what you're going to do.
Right.
What I like is the truth. I'm a big fan of the truth. So I tell people that I'm assuming that you want to know the truth. You did not come here to pay me for me to lie to you and tell you what you kind of want to hear.
Right.
Which is everything's going to be okay. So you're going to do what you want to do. This is what I suggest. I'm telling you your plan won't work, but I'll be right here and I'm not mad.
Right. Waiting with open arms when you're ready.
Yeah.
Yeah. I tell clients that all the time. I love it. All right, so let's talk a little bit about psychiatry and eating disorders, medication management and things like that.
Yep.
And then I think we could maybe wrap it up at that point because in future episodes, I would love to hear what you have to say about just lab work and refeeding syndrome and things like that our clients out there would like to know about.
Yeah. I think that would be fun to talk about because it would help them understand like what the importance of the nursing and the 24/7 nursing care and why we
Right.
need all those full-time medical doctors. So at Eating Recovery Center, because I can't really say this about everywhere, the psychiatrist is really the head of the team, the leader of the team. So do we work collaboratively? Yes, of course we do. We're all the team, but the psychiatrist does the admission and the psychiatrist decides when to discharge. So while we prescribe medicine, because that's, we went to med school to prescribe medicine, but we got a lot of training and other things. So some of us really like to do family work. I'm one of them. Some of us really like to do individual work. I tend to like to do families, multifamily work. That's really fun for me. I'm energized by that. But we also prescribe medicine, and we make sure that they are on appropriate medicine. If they have depression, if they have anxiety, if they have OCD, sometimes they come in because they're not sleeping. We at Eating Recovery Center, our whole system is we approach every patient in trauma-informed care sort of approach. So we assume that people have had trauma because my trauma may not be your trauma, right? And it has to do with your temperament in a way, how you experience things,
perceive it, right?
And what you do with it. So we prescribe medicine, but we also, I guess, corral the treatment or make sure that it's moving forward in the way that it needs to be moving forward. If the therapist needs us to come to family therapy, we go. If we need to do something else, we do it.
Right.
But yeah, I think of us as the leader of the team. We're all full time.
Right.
So that's a different thing, I think, for most places. We're full time, and we just think that that's the appropriate way to do things.
Yeah. So you have some good oversight. You're consulting. You're collaborating. You're making sure the clients are getting what they need.
Yep.
And working together as a team.
Yeah, we do. I tell the doctors all the time when they come in, yes, we are the head of the team. Everybody knows that. We don't need to tell them. We want to work collaboratively with the nurses, the medical doctors, the therapists, the dietitians, and the rest of the staff.
Right. I love that model. In fact, it's similar to the model at the Recovered Clinic. We don't have medical providers right now in terms of psychiatrists or nurse practitioners, but one day soon we're hoping to get that. So right now, the psychologists act as the attending in terms of doing the admission assessment, following the care, checking in with the clients, joining sessions, being a part of the care all throughout, just to make sure that, like you said, we're corralling the treatment and then making sure that the clients are truly achieving, first relapse prevention as the focus, and then recovery, like walking alongside the client in recovery before discharge.
Yeah, I think relapse prevention, it's something that I personally do a group for families and other people, grandparents, aunts, uncles, anybody who's going to be part of the patient's support. And I talk a lot about relapse prevention because I think what happens is that when my patients come in, they don't look good. They look terrible. They might be underweight. They might just look terrible because they've been binging and purging and not sleeping. When they're starting to leave and go back out to you guys and go into intensive outpatient, they look a lot better. They sound a lot better, but their brains are not a lot better.
Right.
The families are tired, and so it's easy to want to do the experiment of we're just going to go back to exactly how life was and see how that works, and it never works.
Right.
We can't do that. We have to. So what I try to tell them is, if you'll just stick with this plan, this relapse prevention plan, for the next 6 to 9 months, then you will be really pretty much home free. But if you go out and you try to go exactly back to the life that you were in when we met you, you're going to come back to the life you're in now, which is with us.
Right. Exactly. So relapse prevention is huge. I mean, we know patients are 11 times more likely to relapse if they don't follow those recommendations.
Yes.
Yes, we do.
we
have the research behind it. So,
Yeah.
So we don't make those recommendations lightly, right?
No. I mean, we liken it. This is what I liken it to. I had boys long before I had a girl, so it's always like a baseball metaphor. But, when you come in at home plate, you'll do anything. You believe us. You think we're smart. And then as we go through treatment, it gets harder. You get tireder. You've got more responsibilities. And then as we round third base, I kind of think of the 6 to 9 months when they leave us and go back to you and they're in intensive outpatient, that third base to home plate, that has got to be as intentional and deliberate as the rest of it.
Yes.
So if you turn on third base and run out into the outfield chasing a butterfly, that is not going to work. That's not how you got there. It's not going to get you home. Exactly. I talk about it every week.
I love it. That's such a good example. I'm going to share that one with my husband, and he'll love it too.
Oh, that's good.
He's a baseball fan.
Oh, that's good. So, yeah, so that's how honestly, I talk about it every week. And it's hard for people to believe it's true, but it is. I mean,
I like it when we actually share patients, so they come to me from you or I send them to you, and I know they're hearing the exact same thing.
Mm-hmm. Yeah,
we're
it
speaking
is
the
so
same
helpful.
language.
Mm-hmm.
You know, it's great.
Yeah, I like it too. It's we need you guys because the reason a lot of the time, not all the time, people are in a situation of coming to us is because they have tried to pursue this very unrealistic, thin ideal that the westernized culture as a whole kind of worships. Mm-hmm. And they get in trouble with it. So they're ambivalent. If that's how they got to treatment, they're ambivalent about treatment because it's so egocentric. It feels so good to them to have in anorexia. It actually doesn't matter. You can lose weight because you had braces. You got braces. You can lose weight because you got really sick. Everybody's going to compliment you if you lose weight.
That's exactly right.
Right? Mm-hmm. So they're ambivalent, and we need the partnering with the outpatient teams because you're the ones that help us. You've got the relationship. We don't know them that well to be able to tell them when they want to leave, no. You're going to stay right there. This is the right thing for you. We talked about this. And if we don't have the partnership, it's much easier for them to, in their ambivalence and impulsivity, to leave treatment. So.
Absolutely. And so for that reason, we talk to each other, right? The professionals collaborate on behalf of the client, and we have to. We can't just take their word for it.
Yeah, we have to. Yeah. We have to. And when we call you, guys, if they say they're leaving, we call, we don't want them to leave. We usually can't make them stay.
Right.
I do have the ability to hold somebody involuntarily on a court order, but we do that rarely. Usually we can talk to them, get outpatient providers to help us, and we can keep them in treatment without having to do that.
Absolutely. I love working with you, Dr. Sutliff.
Thank you.
Thank you so much for coming on today.
You're welcome. I'll come anytime.
Okay, cool. We'll see you soon then. All right, there you have it. That's the Red Clinic Podcast. Can't wait to see you again next week.